Everyone. Hello everyone. Myself I am Dr. Ismail and we are from Everest Surgeons. Today we are going to study the instruments and suture materials. So basically instruments and suture materials during your final year examination of undergraduate or also postgraduate, you will be having one station of instruments and suture materials. So it depends on your marks, it will be 20 mark station or 10 mark station. And apart from that, during your any surgical branch residence, you should be knowing properly about instruments and various types of suture materials. And along with that, if you are going to write some international examinations such as MRCS examination or any kind of examination, so there will be one station based on your instruments and suture materials. So today we are going to start the instruments and suture materials. So basically uh, instruments and suture materials, we are divided into two parts. So one is the first part is our instruments, and we are going to do today only general surgical instruments, and laparoscopic instruments if possible we'll do in some another stations. So basically instruments, we'll be starting with the instruments, and most of the all instruments are made up of stainless steel, and some scissors are made up of titanium material. So instruments is having parts such as you can see in this instrument, there is a ring like hole is there, where you have to put your thumb finger and your ring finger, you have to insert it. There is a ratchet is there. Basically function of ratchet is to stabilize the instrument, and some instrument there are no ratchets, so that your instrument is having proper mobility. And apart from that, there is a shank and there is a joint. So there are two types of joint. One joint is a box joint. In most of the instrument you will be having box joint, and another instruments you will be having your screw joint or pivot joint. So apart from that, there are jaws, and jaws, it can be plain jaws or there can be serrations, and there are different types of serrations are present. So if the instrument is least traumatic, such as our bowel clamp, so there are longitudinal serrations. So basically longitudinal serrations are causing least trauma. And if there are transverse serrations, it leads to maximal stability or maximal grip to hold the tissue or any structure, but there are higher chances of injury to the structures. And our needle holder is having crisscross serrations, and with there is a longitudinal groove in between the serrations. So basically crisscross serration is to hold the needle holder properly, and also for the better grip of the needle holder, and crisscross serration minimize the trauma to the needle and suture materials. So these are the parts of instrument material. So whenever you are going to take any instrument in your viva, or so they will ask you identify the instrument. So first point is you have to identify instruments. So there are characteristics points in the instruments, you have to identify it. Then the next point is you have to tell the parts of instrument. Then the next part is which material instrument is made up of. So most of the material is made up of stainless steel, except some scissors which are made up of titanium alloy. And you have to tell the methods of disinfection or methods of sterilization of the instrument. So coming to methods of sterilization of instrument, so all the instruments are sterilized by autoclave, which is kept at 121 degrees Celsius temperature for 30 minutes. So if you are going to put any kind of catheter such as corrugated rubber drain, or any kind of plastic, or any kind of suppose there are any kind of glassy material or any kind of substances, so depends on the substances. So there are different types for other sterilization methods. So basically for autoclave you have to put 121 degrees Celsius for 30 minutes. Except sharp objects, you should not autoclave the sharp objects such as scissors or any kind of needle, because if you put them in the autoclave, so there it is a formation, crust formation will happen, and there is a loss of sharpness of the instrument. So always avoid putting sharp instrument in the autoclave. And for sharp instrument, there is a ethylene oxide chamber is available, or you can put in the 2% glutaraldehyde chamber, or you can put in the Sidex, or you can put it in the diluted Lysol solution. So never put sharp instruments in the autoclave. So if you tell this much, no, they will ask you next question. So basically in during instrument, you will be basic instrument is your Bard Parker handle, that is called as BP handle. So there are 3 number, 4 number, 5 number and 7. So 4 number Bard Parker handles are available, and there are different surgical blades, and most commonly we'll be using 22 number surgical blade, that is to take the any kind of bigger incision, deeper incision. And 15 number blade is for if you are taking any small cyst, small lipoma, for fine incision. And 12 number blades will be using generally to cut the suture material. And 11 number blade will be using for, it is a pointed blade, so will be using for stab incision in case of incision and drainage of an abscess. So these are different types of blade, and this is the Bard Parker handle. So you should be knowing how to put the blade in the BP handle, so you should not get injured while putting the blades, because blades are sharp objects. So coming to definition of draping, so before starting to the procedure of any OT, first we'll sterilize the area of interest on which we are going to perform the procedure. For sterilization, we are using the povidone iodine solution, 10% solution we'll be using. And apart from that, we'll be using absolute alcohol for sterilization. And after doing sterilization, we'll be draping the area of interest with the material, so that will isolate the area of material or area of interest from the surrounding structure. So that is called as your draping. So draping is very much important because it reduces the chance of post-operative infection and surgical site infection. So you need lots of practice for proper draping. So coming to sterilization, in examination you will get confused with sterilization and disinfection. So what is sterilization and what is disinfection? So this is the basic question they will ask you. So basically, sterilization is the process by which all forms of life, including bacterial spores, are completely destroyed or removed from object or environment. That is called as sterilization. So what is the difference between sterilization and disinfection? In disinfection is a process of same eliminating many or all pathogenic microorganisms except bacterial spores or some kinds of viral particles. You will be not getting removed from the specimen or instruments. So that is called as disinfection. In sterilization, you will be removing all the microbiological organism, but in disinfection there are some kinds of spores or some kind of viral particles will be remaining in the instrument. So that is called as disinfection. So basically there are types of sterilization. One is your physical method. Then physical method, there is a heat sterilization, that is a dry heat, which is hot air oven or flaming or incineration. Basically we'll use the heat sterilization for any sharp objects such as glassware or any metal instruments or any kinds of powders, oils we'll use for the heat sterilization by physical methods. And coming to our, there are also a moist heat, that is our most common autoclave. We'll put, as I told in the beginning, 121 degrees Celsius for 15 to 20 minutes or 30 minutes with intermittent sterilization, that is called as tyndallization. So basically we'll use for all the surgical instruments, and which we are using daily for dressing materials, and dressing material also, or any kind of for draping you are using the materials, or any kind of culture media, so we are putting in the autoclave. So for radiation, there are types of radiation. Gamma rays, basically use gamma rays for if suppose there are any kind of pre-packed instruments. Suppose if there is suture material that is pre-packed in the coverage, so that is sterilized by your gamma rays. So Foley's is also your sterilized, because Foley's is covered in the plastic. So anything which is covered in the plastic, everything which is pre-packed state, that is sterilized by your gamma rays. So apart from your gamma rays, so there are chemical methods, as I told in the beginning, where we can't put the sharp objects in the autoclave. So we'll be putting in the ethylene oxide chamber or formaldehyde gas. So basically, apart from our sharp objects, our endoscopes or any important instruments or any plastic instruments, so we'll be putting in our ethylene oxide. There is a ethylene oxide chamber. And liquid chemical sterilization by using 2% glyceraldehyde. So also endoscopic, and when there is a autoclave is not possible. So coming to instrument proper, so our first instrument is our mosquito forceps. So in examination you have to identify it is a mosquito forceps. You have to tell the parts of the mosquito forceps. You are having borings, and you are having ratchets. Then there is a shaft. Then there is a joint. The joint is in this all the instrument box joint except scissors, that is a screw joint or pivot joint. And at the end there are jaws. Mosquito is a very small instrument. Basically there are jaws. In the jaws there are multiple fenestrations are there. So then what is the method of sterilization? So method of sterilization is used by autoclave. Then what is the use of mosquito forceps? Mosquito forceps is used during, if you are doing any surgery, if there are any minor bleeding from the minor vessels, you have to arrest the hemostasis temporarily. Then you will be using the mosquito forceps to arrest the hemostasis temporarily. And if you are operating, if you are not having any larger forceps, then you can use the mosquito forceps to hold your fascia, external oblique aponeurosis. If you want to do some fine dissection, suppose if you are doing open appendectomy, you want to create the plane between the mesoappendix, so that you have to tie the mesoappendix, so you will be using mosquito forceps for proper to make the plane between the mesoappendix. Or if you want to do any finer dissection, you will be using mosquito forceps. So mosquito forceps is our first instrument. Then coming to our Kocher's forceps. So we have named there are multiple names in the Kocher's. Father of thyroid surgery is also Kocher, and there are the Kocher's incision, Kocher's vein, Kocher's forceps are also available. So this is the instruments. Same, there are borings, there are ratchets, there is a shank or shaft, box joint is there. But important point is there are jaws, and jaws are having transverse serration, and at the end of the jaw there are one aspect it is having tooth, and another aspect it is having groove. So it is tooth and groove. So we'll be having straight or we'll be having curved Kocher forceps. So what is the function of this tooth or serrations or groove? Basically, if they are suppose Kocher's forceps is also a type of hemostatic forceps, so we'll be not using in the delicate structure because there are tooths, because there are grooves, so it leads to tissue injury or it leads to more bleeding. So where will you use it then? So we'll be using, if suppose if you are having any RTA or any head injury, so there is a bleeding from scalp. So scalp, what will happen? Scalp is a tough structure, so automatically there is a galea aponeurotica. So automatically any vessel is there in the scalp, it will retract and it will bleed like anything. So you want to crush it or you want to hold it properly, you want to arrest the hemostasis in that case. So tough structures such as scalp and palm or your sole, if there are tough structures, bleeding from the tough structures, or if there are any fascia in which the vessels are retracted, so you want to arrest the hemostasis immediately, so you will be using the Kocher's forceps. So that is the important of Kocher's forceps to arrest the hemostasis in your any kind of tough structure, scalp, your sole and your palm, to arrest the hemostasis. And also suppose if you are performing hemithyroidectomy, you want to remove the part of one lobe and also isthmus, but thyroid lobe is the more vascular, so there will be higher chances of bleeding. So you will apply Kocher's clamp at isthmus so that it will arrest the bleeding. So first Kocher's used during thyroid surgery, so it is called as Kocher's hemostatic forceps. Same, it is also sterilized by your autoclave only. So coming to our types of retractor, so basically retractors, what are the functions of retractor? Retractors are the instruments which will retract the tissues so that your area of interest or your area of operation will become more prominent, or it will be showing you prominent to the tissues of interest which you want to operate. So there are types of retractors are there. One is our Langenbach retractors, Doyne's retractors, Zerni's retractor, mastoid retractor, Dewar's retractor, Morrison retractor, malleable retractor, and Finoshita 4-blade retractor. So this Finoshita 4-blade retractor is there. Basically this Finoshita 4-blade retractor will be using during the thoracic surgery to retract our rib cage, or if suppose you are operating in the newborn child with a tracheoesophageal fistula where you want to retract your rib space, because newborn ribs are easily malleable, so you can retract it properly compared to adult ribs. So you will be using Finoshita 4-blade retractor during thoracic surgeries or any kind of newborn thoracic surgery such as tracheoesophageal fistula, any kind of thoracic surgery you will be using the Finoshita 4-blade retractors. So coming to our first retractor, that is your Langenbach retractor. So whenever you are having a Langenbach any kind of retractor, so one part there is a grip to hold the retractor, okay? So the next part there is a groove in the retractor, and third part is the angle. So in this part there is a groove and there is a round shaped space is there. So why there is a round shaped space or fenestration is there? Because to make the instrument lighter, because you are going to operate surgery for longer duration. Suppose if you are operating any Whipple surgery, suppose you are operating any supramajor surgery, so it will take 6 to 8 hours minimum. So to avoid the weightage of the instrument, to make it more lighter so that you will be not get it exhausted, so that's why they have provided serration for better grip to make the instrument lighter. And there are L-shaped retractor is there, so to the L-shaped terminal end is there to retract it. So where does we use the Langenbach retractor? So basically Langenbach retractor will use in the to retract only superficial and up to subcutaneous tissue. You will be not using Langenbach retractor for deeper tissues. So for deeper tissues, you need some other retractors such as Doyne's retractor, Morrison's retractor, and Devar's retractor. So in examination, myself also I got confused multiple times how to differentiate between this Doyne's retractor and Morrison retractor, because both looks almost same. And in the examination also, in the state of hurry or in the state of fear, some you will be always having confusion between Doyne's and Morrison retractor. So there is also one gripping end is there. There is also one hole is there. So many people they'll hole is there to make it lighter. So many people they will identify with some other thing like hole is like vertical in this part, and Doyne sees it is central. So there are some other instrument where you look similar. So how to identify between Doyne's and Morrison retractor? See at the terminal end of retractor part. So in Doyne's part, terminal end of retractor, it is like a proper D-shaped bend is there, or it is properly having curvature with a D-shaped curve is there. But if you see the Morrison's retractor, it is going almost vertically and it is bending almost at vertically. So it is going vertically, again it is having bending perpendicularly, that is 90 degree, and there is flat or mild depression is there compared to a Doyne's retractor. Doyne's retractor is having proper curve with proper groove to hold the tissues. So this is how you identify Doyne's and Morrison's retractor. So basically Doyne's and Morrison retractor you will be using during deeper structure for retraction. Suppose if you are operating cholecystectomy, so you want to retract the liver to see the gallbladder fossa properly, so you will be using the Doyne's or Devar's retractor in that aspect. So next part is your Devar's retractor. So Devar's retractor is a basically sickle shaped retractor. There is a terminal end that is a sickle shaped and another part that is a proper holding end. So Devar's retractor is also used for deeper tissue retraction for any organ. Suppose during you are to splenectomy, you want to clamp the splenic pedicle, so you can use for to retract the spleen. Or if you are operating any major surgeries, you want to see the retroperitoneal structure but your bowel coming in between. So in that aspect you can keep your gauze or your mop, so that on the mop you will be keeping your Devar's retractor. You will retract all the intestine, small bowel, large bowel at one side, then you will be approaching to the retroperitoneum. So Devar's or any Doyne's retractor, Morrison retractor is basically for deeper tissue retraction or any kind of solid organ. So these all the retractor you will be having assistant. So there will be chances of assistant getting fatigued. So there are chances of assistant interfering you during surgery. So there is a retractor called as mastoid retractor. These are the self-retaining mastoid retractor. So self-retaining mastoid retractor we can use in the spine surgery. Basically you will be applying two retractors in the spine surgeries, or you will be using in the thyroid surgeries where you want to you don't want any kind of interference. So mastoid retractor you can use in the, these are the self-retaining retractor. So coming to Zerni's retractor is also type of Langenbach retractor. Okay. So in that part, Zerni part, one point you will be having complete L-shaped retractor, but at another point you will be having two hooks with fenestration in between them. So what is the use of this hook with fenestration? So I meant, suppose if you are retracting the any kind of structure, suppose you are retracting a spleen or any kind of liver, these are the sharp objects. So you will be using any kind of Devar's or Doyne's retractor. But if you are using any kind of some important vessel bleeding, you want retraction, and simultaneously you want to take the suture to arrest the hemostasis. So that space is there, no? That space you will be putting your needle holder. So in that space you are taking the suture. For the movement of needle holder, that Zerni's retractor between the hook space is available. This is how you identify the Zerni's retractor. So you will be having retraction simultaneously. Along with that you will be putting the needle holder in that space and you will be catching the vessel or you will be tying the vessel. So that is the importance of Zerni's retractor. Coming to our another retractor, one is called as single hook retractor and another is a cat's paw retractor. So single hook retractor, it is easy, it like same like BPA handle with terminal one hook is there. Cat's paw, you can identify the sharp cat's paw is there available with one other end L-shaped retractor is there. Basically single hook retractor or cat's paw retractor, it is used to hold the delicate structure like skin and all. Suppose if you are operating modified radical mastectomy, you are taken the incision, you want to raise the flap. So to raise the flap you will be holding only the skin. So your flap thickness will be up to 8 to 10 mm. So that you want to hold the only delicate structure. To hold that skin flaps, you will be using single hook retractor or cat's paw retractor. Suppose if you are operating thyroid surgery, you want to raise the subplatysmal flap. So in that skin and subcutaneous tissue, subplatysmal flap, you will be using the single hook retractor, cat's paw retractor. These are the delicate retractors to hold the delicate structures. So coming to you have draped everything and your assistant is asking you to start the cautery or put the suction drain or any kind of mop. So you want to secure the your all the suction drain, cautery, and any other things on the draping part. So you'll be using the towel clamp. So one is our back hose towel clamp. So this is our back hose towel clamp, and another one is our Mayo's type of towel clamp. So Mayo's type of towel clamp, it is having a pincer like action. If you press it, it will open. If you leave it, it will close. So Mayo's and backhouse towel clamp will use during the draping to secure the instruments with the draping, so that it should not get fallen while operating on yourself or on ground, because it leads to disinfection. So apart from your holding the instruments, holding the cautery and all, so where do you use the Mayo's type of bowel clamp? So you will be using, suppose there are flail chest. So what is the flail shape? Two or more than three segments of rib fracture at three or multiple sites. In that, patient will be having paradoxical breathing. So instead of expiration, during inspiration, so there is outward movement of chest, but during inspiration, instead of outward movements due to flail chest, the chest will be moving inside. So patient will be having paradoxical breathing. So because of there are multiple rib fracture, you and the rib fractures, if there are sharp end of rib fracture is there, it is going and penetrating your pleura, it is causing more injury. To prevent the temporary hemostasis, to prevent the temporary injury, you will be using Mayo's type of towel clamp, or you can use the backhouse of towel clamp, so that you hold the all the segments of rib together. So this can be used in the your flail chest and rib fractures, multiple rib fractures. So coming to our seizure, so basically seizures are also having boring is there, but seizures it doesn't have basically ratchets, so that you will be having movement of like mobility, you will be having maximum greater mobility. So you will be not having ratchet, you will be having boring to hold the instrument proper, you will be having shaft, but here there are the box joint is not available. In all the seizures it is screw joint or pivot joint. So apart from that, there are blades are there, so blades or jaws are there. So jaws are these are the sharp instruments. So basically Mayo Caesar, the Mayo Caesar will be using during surgery, during cutting of any tough structure such as fascia. You want to cut the skin, you want to cut the aponeurotic structure, linea alba. So you'll be using Mayo Caesar. And the another Caesar is our Metzenbaum Caesar. So Metzenbaum Caesar is basically it is used to cut the delicate structure. If you are cutting any vascular structure, if your cautery is not working, you want to raise the flap by fine dissection, so you will be using Metzenbaum Caesar in that aspect. So this is the Metzenbaum Caesar. So our next Caesar is our McIndoe Caesar. So this is the McIndoe Caesar. So how do you difference between McIndoe Caesar and our Metzenbaum Caesar? Because both are looking same, the only difference between them is our jaws. In Metzenbaum Caesar, the jaws length is more, but in McIndoe Caesar, our jaws length, jaws mean this terminal and sharp part is there, no? That jaws length is less in McIndoe Caesar. Apart from that, all the five features are same. McIndoe Caesar use also same, we will be using in the fine dissection during elevation of the flap, during vascular surgery to cut the vessels, during appendicectomy you want to cut the base after ligation. So any fine dissection you want, you will be using Metzenbaum Caesar and McIndoe Caesar. So this is a Heath suture cutting Caesar. So you can easily identify there is a sickle shaped gap at the terminal jaw, and this is the used to cut the basically suture material. Suppose if you are operated any case, you have taken the skin incision, you want to remove the suture material of the skin after 8 to 10 days depend on the site. So you will be removing the suture with your Heath suture cutting Caesar. So this is the Heath suture cutting Caesar. So these are the sutures done. So remember one point, sutures any kind of scissors will be autoclaved sterilization done by using ethylene oxide, never autoclave. So coming to a drains, so there are active drains and there are passive drain. Historically important drain is corrugated rubber drain, but we don't use that much of corrugated rubber drain because there are higher chances of surgical site infection. So this is the corrugated rubber drain. You can I have told no beginning autoclave for other instrument for 30 minutes. Corrugated rubber drain you can do sterilization autoclave, but you have to keep only for 15 to 20 minutes or else it will melt down. So corrugated rubber drain, where you will use the corrugated rubber drain, suppose if you have operated any case of you have removed the excessive breast tissue, or you are removed any kind of like hydrocele, you operated hydrocele, you are thinking that your hydrocele you operated, you will be developing some kind of scrotal hematoma because of poor hemostasis or because of any vascular coagulopathy. So you will be just putting the corrugated rubber drain for 48 to 72 hours. If there are any collection, it will drain out after 48 72 hours. Remove the corrugated rubber drain and take the skin closure incision, skin closure bite. So suppose these are the associated higher chances of infection. So that's why nowadays we are using the Romovac suction drain. There are multiple parts of Romovac suction drain is there, but this white structure you are seeing, that is for collector, that is for collection of the any kind of secretion. You have to daily, you have to remove the secretion, you have to charge it, you have to decharge it. See, basically you have to measure the drain output, how much drain output is coming. Suppose if you are operating case of modified radical mastectomy, so post mastectomy, one you will be putting the drain at the pectoral area, one you will be putting drain at your axillary area, so that you want to monitor the drain output. So suppose you have kept the drain for 3 to 4 days, if the drain output is less than 30 to 40 ml within 24 hours, so that is the indication to remove the drain. So you should not be keeping drain for longer duration because it leads to surgical site infection. So this is the Romovac section drain, this is the active drain, not our CRD. And coming to our abdominal drain, so suppose our abdominal drain is there, you have operated any kind of pre-pyloric perforation, you have operated the pre-pyloric perforation, you are repaired nicely, but you want to see, you have given proper bowel wash, you have given everything, you have like proper bowel wash is there, all the slough and all the material you have removed, but still you are thinking in terms of any collection is there, any residual collection is there. So you will be keeping the two drains, one in the subhepatic fossa, one in the pelvic area, so that you want to see any collection is coming or any leakages from the pre-pyloric perforation side. So basically to remove the substance which are accumulated in the abdominal cavity. So according to the recent ERAS protocol, you should not put any kind of drains, but drains are usually, these are the indication for any early anastomotic leak, so that you will go and reoperate the patient earlier. According to ERAS protocol, there are no indication to keep the drain, there are no indication to put Riles tube, there are no indication to put catheter to all the patient. So but in the practice we will be putting the abdominal drain to monitor the suppose you have done resection and anastomosis. So if you're on day 5 or day 6, you are drain through the drain site, you are seeing the feculent material is coming, so you'll be suspecting anastomotic leak. So you have to explore the patient before developing full blown feculent peritonitis. So that is the important of keeping your abdominal drain. So basically there are markings 25 ml, 50 ml, 75 ml, 105 ml. So basically you have to monitor the drain output. Basically you will be taking for any, if you want to do any culture, you will be doing any culture. Suppose you have operated perforated appendicitis with peritonitis. So through drain you will be giving drain wash through metro. In our institute we will give the drain through the drain, we will be giving metro wash to remove the any collection in the inside the abdominal cavity. So in examination, never get confused with abdominal drain and intercostal drainage bag. Suppose you have inserted ICD, so you will be having communication with your you will be putting to you will be having communication with your intercostal drainage bag. So intercostal drainage bag, so you will be seeing one, not like vertical lines in the abdominal drain, you will be seeing one line is there, so that is the air fluid level. So you have to keep the fluid up to that dotted line is there, so that dotted line you have to keep the fluid till that line, and central part is there, central one white color part is there, straight tubing. So you will be saying the central part you have to move the air column movement. So your air fluids level should be up to dotted line, you will be seeing the air column movements. So depends on air column movements, you have to see like when to remove the ICD, or depends on you for any, you have put the ICD for any pleural effusion, for hemothorax. So there are markings, so that you have to measure the output. So depends on your output, depends on patient condition, depends on your air fluid levels. So you will be taking decision when to remove ICD and all. So never get confused between intercostal drainage bag and abdominal drainage bag. Intercostal drainage bag, there is a central air fluid level collection is there. So that is the important point. And one more point is also there. So there is a one closure point is there at the intercostal drainage bag. So after putting ICD, never close the closure point, because if you close the closure point, again it leads to formation of pneumothorax, again it leads to formation of your closed cavity. Always remove it, so that it is having communication with your atmosphere. So that is the important point of your drainage. And coming to our this is the Euro bag, so it is named will be Euro bag. So many times it will be named Euro bag, abdominal drain bag. If you are not having any kind of hint in the examination, just see and read it properly. So that is a euro bag. Basically euro bag will be using for, if you are, suppose if you are operating in the peripheral setup, there are no abdomen drainages available, you can keep the Foley's also inside the abdomen instead of your abdominal drain. If there are no available drain, will be putting multiple times Foley's also you can put. So same like Foley's, euro bag, you have to measure the output, you have to take the collection for culture. So what is the Foley's? Foley's is you will be putting the Foley's to measure the urine output, or if there are any patient is having bladder outlet symptoms, if the patient is having any prostatism, so we'll be putting the Foley's to take out the urine from the bladder in acute retention, or it could be any chronic retention. So Foley's is made up of latex rubber tube, or any silicone Foley's is also available. Silicone Foley's will be keeping for maximum 1 to 2 months we can use, and latex will be removing after 8 to 10 days. So there are different based on color coding is there. So in this image you are seeing the orange color Foley's, green color Foley's. So based on color coding is also available. So that at the tip of end you are seeing one color is there, no, that is your green color. So based on color you have to identify. So if if the numbers are not available, green Foley's means 14 gauge, orange Foley's means your 16 gauge, red color means your 18 gauge. So that is your French gauge size. So what is this 8 gauge, 14 gauge sticker? So basically it is the circumference measurements. So basically it is the circumference measurement. So Foley's, it is having one part is at your eye, that will be inside your bladder, that is your bladder opening. Next part is your balloon is there, okay. So next part is your balloon, next part is your drainage tube, and next part is your urine. There are 2 waves and 3 waves Foley's are there. One is the urine drainage port is there, and also one is to the balloon inflation. So this green color part you are seeing, no, balloon inflation, and also in that you have to see the how much you have to inflate. So basically never use saline for inflation. In examination they will ask you which fluid you will use. So always use your isotonic fluid or any kind of your distilled water you will be using. Never use the saline, because if you use saline, no, it will leads to formation of crystallization in the balloon, and you will be having difficulty in removal of the Foley's. So always use your distilled water during inflation. So in that it is written 14 French Foley's size and 30 ml capacity. So inflate up to 30 ml. Don't inflate more than that, because it leads to rupture of the balloon inside your bladder. So this is the Foley's. So Foley's is sterilized by your it is pre-packed, so it is sterilized by your gamma rays, okay. So apart from that, you have to know, you should be knowing how to insert the Foley's. There are multiple mannequins available how to insert the Foley's. So there are different types of catheterization in male urethra, female urethra. So you will be knowing how to put the Foley's. So apart from that, what are the different uses of Foley's apart from your routine for urine drainage? So one I have told you, will be using during your if there are no drains available, you will be using in abdominal surgeries as the replacement for drain. And if there is suppose you are operated any case of so if you are you want to pleural effusion is there, pneumothorax is there, hemothorax is there, but you are not having ICD, intercostal drainage tube. So in that part you will be using, instead of ICD, you will be using Foley's. So Foley's will also serve the same aspect. So apart from that, if you are having any patient of diffuse external injury, head injury patient is there, patient in the vegetative state, so up to 2 weeks only you can put the Wright's tube. So apart more than 2 weeks Wright's tube, it leads to nasal crusting, it leads to epistaxis. So you'll be not giving that much of bolus food. So there is a nutritional imbalance between demand and supply. So in that case, more than 2 weeks, remember one thing, more than 2 weeks you want to give the supplement to the patient, you have to start doing any alternative methods by doing depends on the condition. If the patient is having paralysis, if the patient is having CVA, so you will be doing feeding jejunostomy more than feeding gastrostomy, because in feeding gastrostomy there will be loss of lower esophageal sphincter mechanism. If you put any food in the stomach, it will lead to aspiration and regurgitation and aspiration pneumonia. So in that CVA patient you have, or any kind of diffuse external injury patient, because there is a loss of lower sphincter tone, so in that condition you will be doing feeding jejunostomy. For feeding jejunostomy also you can use the Foley's as a replacement for your appendix, as a replacement for your abdominal drain, and as a replacement for your intercostal drainage tube. And suppose you have done the appendicectomy, you are thinking in terms of any like you are thinking in terms, you have done appendicectomy, but you are not done the base fixation properly. So you will be having risk of leakage from the stump of the appendix. That is one of the deadly complication. So in that part, what you have to do, you have to because cecum is usually high pressure zone. So what you have to do, pass the Foley's from the cecum, take from the ileum, break your ileocecal junction. Okay, so that is making your ileocecal junction incompetent, so that leak should not happen. And also during tube cecostomy also you can be use the Foley's. So those are the uses of your Foley's. So coming to our needle holder, so needle holder, as I told you in the beginning, it is having your boring, it is having rachets. Okay, so it is having your shaft, it is having box joint. How to identify needle holder? Basically needle holder is having jaws, but jaws are having crisscross serration with longitudinal groove in between the serration for proper holding of the grip of the needle, and also to cause the least trauma. And also very much important point, the jaws or end part of the needle holder is smaller in size compared to the rest of the aspect of the instrument. So you have to go and see the jaws. The jaws are smaller in size compared to whole of the instrument. This is how you will be the whole identify needle holder. So this was the crisscross serration which I was telling you, with longitudinal serration in between the needle holder. So this is the typical of box joint. So there are two types of needle holder. If your needle holder you are using for deeper structures you want to tie, so in that case you will be using the Mayo's needle holder. If you want to tie only superficial structure, in that case you will be using Osland and Hagar needle holder. So there are Mayo's needle holder and Osland and Hagar needle holder. So coming to our suture material proper, so suture materials are basically classified into, first classification is your whether suture material is synthetic, whether suture material is artificial. Next classification you will be having suture material whether it is absorbable and whether it is non-absorbable. Next classification is whether suture material is monofilament or suture material is multifilament. What is this classification of synthetic and what is the classification natural? So if you are getting from natural directly, suppose if you are getting silk from, you are getting from any kind of cocoon or cocoon, Bombax mori, so that is a natural. If you are getting catgut from submucosa of the sheep or mucosa of the any kind of bovine, so that is the natural. And all other suture materials are basically artificial. So that is your synthetic and natural. Coming to your absorbable and non-absorbable. So most of the sutures, if the suture is natural suture, it will undergo enzymatic digestion by body itself. So whenever the natural suture material will undergo degradation by enzymatic degradation, so it leads to most of the tissue reaction or formation of tissue granuloma. It is a immunogenic natural synthetic material. But our artificial suture material, it will undergo degradation by hydrolysis. So that is the difference. So one is our natural by enzymatic degradation. Our synthetic suture materials will go degradation by hydrolysis. It leads to least tissue reaction and least formation of any kind of suture material granuloma. So that is the important of types of degradation. So absorbable and non-absorbable suture material. And next next one is a monofilament and multifilament suture material. What is the monofilament? Basic is common sense. Monofilament means single thread, multifilament means multiple threads are there. So what is the advantage of multifilament? So multifilament, so basically when you are taking the multiple filament suture material, it is having more capacity or more strength of the knotting. It is having better grip to hold the suture. But what are the disadvantage? If you are when you are taking the multiple filaments, during the in between the each filament there are the spaces or there are cavities. So there are higher chances of development of bacterial infection in the multifilament suture. And also imagine one thing, if you are passing one thread through your skin, that is fine. If you are passing some 100 thread through the skin, it leads to more tissue injury and more tissue trauma. So that leads to more tissue injury and more tissue trauma. So monofilament suture, it will glide easily through the tissues. It is least immunogenic and it leads to least reaction, but it is having poor knotting capacity. So that if suppose you are operating with the Prolene, you have to take some 8 to 10 bites to secure the knot. Minimum you have to take the 8 bites to secure the knot. Not in the aspect of you are taking Vicryl or you are taking the silk, your 3 or 4 knots are enough. But the knotting capacity is good in multifilament, poor in your monofilament suture. So example for absorbable natural is your collagen, absorbable synthetic yours monocryl, Vicryl, PDS. These are all the brand name. And non-absorbable suture synthetic is your Ethylone, Prolene, and natural is your silk. So silk is only natural but non-absorbable suture. Okay, remember from this thing. So when you are suppose your suture sutures, no, there are needle. So there is a needle in front of the suture. So these are the parts of needle. So what are the parts of needle? Go to my left side, there is a needle point, that is a sharp end, and after that there is a needle body is there. Okay, and at the end, at the terminal part, there is a swag end. From swag end, one eye is there. From one eye the suture material will pass. Like how will the put the suture, like from the eye, no, eye is nothing but that fenestration. Through the fenestration we are going to the pass the suture material. So there are atraumatic or eyeless suture material is also needle is also available. So when you what are the importance of eyeless or atraumatic needle means? So it leads to least trauma compared to your needle is having with the eye. So that is the only difference, which needle with eye causes more trauma, but needle without eye or it causes least trauma. So that is the only one difference is there. So these are the needle point, and one thing you have to remember, one is needle length. So basically NEET or any kind of competitive exam, no, they will ask you what is the needle length. So needle length is your circumferential distance between the needle point to swag end. So what is the needle length? That is the circumferential distance between the needle point and swag end. So what is the needle chord length? So that is your linear distance between needle point and swag end. One is circumferential, so one is a needle chord length. Okay. So when you cut the needle at the body of the needle, you'll be getting one cross section. So depends on the cross section of the needle, you'll be having round body needle, you'll be having cutting needle, you'll be having reverse cutting needle, you'll be having taper point needle, you'll be having plain needle. Okay. So depends on, not at the needle point. So most of the you'll be having confusion, no, what is a taper point, what is a round body. It does not depend on your at needle point. It depends when you cut the needle at the body, in the, if you are getting at the cross section. So if you are getting any round body near taper point, reverse taper point is there, so you'll be getting at your needle body, not at your needle point. So where you want to hold the needle exactly, you have to hold the needle at anterior 2/3 and posterior 1/3 junction with the needle holder for proper suturing. Okay, where you want to hold anterior 2/3 and posterior 1/3. So which one is the weakest point in the needle? So near to the eye or near to the swag, that is the weakest point, you should not hold there. It leads to breakage of the needle. So these are the points of needle, and as I was telling you, okay, so when you cut the needle in the body, so you'll be getting the cross section. First one is our taper point or round body needle. So basically taper point or round body will be using, suppose if you are operating any resection and anastomosis, you will be using round body needle. Why? Because it leads to least trauma to the tissues, because you are handling the delicate structures. Okay, it will glides through the tissue, but it does not leads to any lateral damage to the tissue. So that you are operated any case of resection and anastomosis, you are using the conventional cutting or reverse cutting. What it leads to? It leads to adjacent tissue injury. So there are higher chances of anastomotic leakage. So selecting suture material is very much important as selecting the surgery. So this is the important part, taper point or round body needle. So what is the use of blunt point needle? Suppose if you are operating any case of liver injury is there, but the liver laceration is there, that is only grade 2 or grade 3 liver laceration is there, but bleeding from the liver. So you want to do the you want to just do the, you want to take the suture material, or you want to keep some Abgel, or you want to keep some sponge for temporary or permanent hemostasis. But in that point, no, taper point round body also, if you put the round body, it leads to again bleeding. If you put the conventional cutting, it leads to massive bleeding. So in that point, you will be using the blunt point needle for any kind of solid organ injuries such as liver and spleen. To arrest the hemostasis, you will be using blunt point needle. Remember this point. So there is a conventional cutting and reverse cutting. Conventional cutting, apex of the triangle will be facing the curvature of the needle. Reverse cutting, it will be facing the downwards, away from your curvature of the needle. So basically conventional cutting and reverse cutting you will be using for skin and any tough structures. You will be using this part. Okay. So taper point you will be using most of the time during anastomosis, vascular anastomosis, resection and anastomosis. Okay. So that is the important. So when you are dealing with the suture material, there are multiple terminologies are there. So the examiner, they want you to get confused with these terms: memory, plasticity, and what is elasticity. So what is memory? So memory is by, suppose suture material is there in your proper packing. So you have taken out the suture material. ठीक है. So when you have taken out the suture material from your packet or your suture packet, ठीक है, suture when you have taken out, suture should come back to your like where if you stretch it, it should come back to normal position. But you have taken out the suture material out of your suture package, but suture material is not taking proper size. Suture material is taking initial position or initial its shape of your package only. So that is called as memory of suture. Suppose it goes with your proline. You have taken the proline, you have taken the ethylene. Those are the monofilament suture are having good memory. Suppose if you have taken the proline from your suture material, ठीक है, you will ask your assistant to make it straight. ठीक है, you will be asking your assistant to make it straight, make it straight, make it straight. So then it will go and become your straight. If you leave it, no, like without making any straight and all, it will regain its normal shape. So that is called as your memory. So suture material with good memory, remember this, suture material with good memory, those are having your knotting capacity very poor. There are higher chances of knot slippage or knot ligature slippage. So you want to take some 6 to 8 knots in the proline. So that is important of memory. Okay. So apart from that, if the suture again it coils, there is also difficult handling. It will fall in the down. So that is important. So example is your proline or example is ethylene. So what is the plasticity? Plasticity is okay. So you have taken the suture, you have stretched it like you have stretched it completely. So you have stretched it. Suppose if the size of your suture material initially it is 1 centimeter, okay, you have stretched it and it's become 2 centimeter, and you have removed your force. So you have removed the force completely. So your suture material it will be and it will get stay at the 2 centimeter only. It won't go back to the 1 centimeter. So that is called as plasticity. If you stretch it, it will become 2 centimeter. Okay. If you leave it, it won't come back to your normal position. That is called as plasticity. So what is this the disadvantage of now plasticity? One advantage, you will be knot will be good. You will be having secure knot. Okay. But what is the important of this plasticity? What is the disadvantage of this? Suppose you have you have tied any vessel using this suture material. So post operatively, if there is any, if the initially during operation, no, vessels will go into vasospasm and all. So there is a temporary arrest of hemostasis, and you have taken one suture material. Okay. So do you think in the post-op, if the due to blood pressure and all, suture due to blood pressure, because immediately post-op, no, patient will be having hypertension due to agitation something, your vessel will expand. If your vessel will expand due to hypertension, in that time also suture is there. Okay, because of plasticity, no, your suture will get stretched. It will come into the 2 centimeter to 4 centimeter. But after once the patient becomes stable, your vessel again will go into collapse, or again it become normal state. What will happen to your suture material? It will stay in the 2 centimeter or 4 centimeter. So that condition, it leads to more of bleeding or more of bleeding up to, again leading to reactionary or secondary hemorrhage. So that is the important of your doing your plasticity. So what is the elasticity? Elasticity is basically same like memory, but in elasticity, suture returns to its original length after being stretched when the force is removed. So suppose in the memory, like if it, for example, you have taken any 1 centimeter suture, you have stretched it properly, so it will become 2 centimeter. Okay, you leave it, it will become again 1 centimeter. That is elasticity. But in memory, only 1 centimeter suture you are stretching, it is not going, it is not extending or not becoming expanding, and it is becoming again 1 centimeter. If suture material after extension becomes 1 centimeter, that is memory. If it is become 2 centimeter and again it comes back to normal position of 1 centimeter, that is your elasticity. So in examination also never get confused with your elasticity and memory. So that is the important aspect of elasticity and your memory. So there are different types of needles are available. So okay, based on 360 degree circumference, okay, based on half circle, 3/8 circle, 1/4 circle, 5/8 circle, J shaped or compound curve or any kind of straight types of needles are available. So basically, I will be starting with the suture material. So first suture material is our catgut. So in examination, when you get some suture material, examiner will ask you, take one suture material, describe the characteristics of this suture material. So first you have to tell whether which kind of suture material. So this is the catgut. Okay. So they'll ask you what is the origin and all. So you have to tell catgut is origin from your submucosa of the sheep intestine, and or you can tell it is the intestine aspect mucosa of your bovine intestine. Okay. So what are the types of catgut? You will be having plain catgut and you will be having chromic catgut. There are two types of catgut. One is plain catgut, another one is your chromic catgut. So plain catgut is the using it will get absorbed within 60 to 17 days. Okay. So this is the natural, this is the multifilament suture material. So it leads to more tissue reaction. What is the chromic catgut? So our catgut, no, plain catgut, it will get absorbed within 60 to 70 days. But our chromic catgut, after treating with chromium salt, 20% of chromic acid, you are treating with that, so that you want to delay the absorption, and also you want to reduce the tissue reaction. So it will get from 60 to 70 days of plain catgut, it will become absorption time of 90 to 100 days. So that is the important of your chromic catgut. So this is the catgut, no, it is derived from the sheep submucosa or mucosa of bovine organisms. So you want to limit your any immunogenic reaction, you want to keep any antibiotic solution, so that patient will be not having any kind of immunogenic reaction or infection. So that you will be having additive, it is called as isopropyl alcohol. So whenever you are taking the chromic catgut suture material, you will be feeling some liquid substance. So that is your isopropyl alcohol. Basically we will be using catgut in the circumcision, or you can use anything in the for subcutaneous suture to remove approximate the or close the cavities. We will be using most commonly in the circumcision. So this is our natural absorbable multifilament suture material, that is a catgut. So next is our synthetic absorbable suture material, that is Vicryl, that is a brand name, but its generic name is a polygalactine. Why it is called as polygalactine? Because it is a copolymer of 90% glycolide and 10% of lactide. So it is a braided, means it is a multifilament. But if you take Vicryl 60, Vicryl 70, those are the monofilament suture material. Okay, if you take Vicryl 1020, those are multifilament, but if you take finer suture material, so those are your monofilament suture material. So as I told you in the beginning only, this is the synthetic suture material, so it degrades by hydrolysis mechanism. So maximum it will get absorbed by 60 to 90 days. But there is one Vicryl is there, that is called as rapid Vicryl, which will get absorbed by within 40 to 45 days only it will get absorbed. So how this Vicryl to rapid Vicryl conversion will happen? You have to treat the Vicryl with your gamma radiation. So what it leads to? It leads to decrease in the molecular weight of the Vicryl, so that Vicryl will turns into the rapid Vicryl. So it will get absorbed within 45 days. Okay. So where will you use the Vicryl? So Vicryl is basically most of the surgeries, no, you will be using Vicryl. So you'll to as I told you, like to approximate the subcutaneous tissue, or you want to take the any purstring bite, or you want to secure the base of the appendix, you want to use the hemostasis tunicus, and there are multiple port closure Vicryls are also available. For that you will be using during suppose you are operated laparoscopic appendicectomy, you want to close the umbilical port for the port closure. So basically for subcuticular suture, or you have taken any some salivary gland tumors or salivary gland cyst from oral cavity, you want to approximate the mucosal suture. So that condition also you will be using the Vicryl, or for circumcision also you can use. So there are multiple uses of Vicryl. So coming to our next synthetic absorbable, that is a monocryl, that generic name is your polycapron. So this is a synthetic, this is the monofilament suture material. It is made up of 75% glycolide and 25% of caprolactone. It also is synthetic, so it will go degradation by hydrolysis, and it will get absorbed within 90 to 120 days. So basically this is the cosmetic suture we will be using for most of the time subcuticular suture. Suppose you are operated thyroidectomy in female patient, you don't want to give any scar, so you will be taking subcuticular running suture by taking monocryl suture material, or you can use in the circumcision also. But one problem is that it will get 90 to 120 days, the delayed absorption there, no, it will lead to the foreign body reaction. So coming to our natural non-absorbable suture material, our only one example is that is the silk. So silk is the multifilament suture material. It is a derivative of Bombyx mori, that is the silkworm. Okay, it belongs to non-absorbable, and it is slowly degraded by enzymatic reaction because it is a natural. So it will lose its strength by 1 to 2 years. So there are higher chances of tissue reaction, and it is having good property of knot holding, and it is having good property of handling because it is a multifilament suture material. So basically we'll use the silk during the, if there are any bleeding from the vessel. So basically to arrest the hemostasis we'll be using the silk. Apart from that, you can use the most of the time during resection and anastomosis of the bowel, or you will be using during the subcutaneous suture also you will be using the silk. So silk belongs to your natural multifilament non-absorbable suture material. Okay, so this is the silk. So silk is the basically silk, if it is having eyeless or atraumatic needle. As I told you in the beginning, there are eyeless needles are also there. Those are associated with least trauma, which will be using the more delicate structures, say vascular anastomosis and all. So that is called as your merce silk. So basically merce silk is your silk suture without eye at the needle end. Okay, so that is your merce silk suture. So next is coming to our non-absorbable synthetic suture is our Prolene. That the brand name is Prolene and generic name is polypropylene. It is a synthetic non-absorbable suture and it is a monofilament suture. And it basically it is a it gets the absorption very late, up to 2 to 3 years it will take time. But this is the monofilament suture. It is having least tissue reaction, and also along with that it is having higher chances of knot slippage, so that you have to take some 6 to 8 knots while tying with the Prolene, but it leads to lower tissue reaction. And this is also having good memory, because it if you take out the Prolene from suture material, no, again it will go and take the shape of the suture material only. So you have to stretch it, you have to make it at the normal position. Where we'll use the Prolene? So basically Prolene will be using during vascular anastomosis, so that you will be not having future leakage. You will be having, suppose there is a tendon injury, any ligament injury is there, those are the avascular structure, so it will heal by fibrosis. Okay, so in that aspect you will be using the Prolene material during plastic surgery also, or to hold any ligaments or any tendon injury. So basically, one point you just remember, if you will be not using this kind of non-absorbable suture in any kind of tubular structure, such as common bile duct or any ureteric anastomosis. Okay, so you'll be not using any kind of suture material in this aspect. Suppose you see common bile duct injuries there, if you are using the Prolene, no, so Prolene will get absorbed very lately, so there are higher chances of formation of stones within that. So never use the non-absorbable suture material in the common bile duct or any ureteric injuries. So coming to our next non-absorbable synthetic material is our Ethlon. The brand name is Ethlon and generic name is your polyamide. Okay, it is also monofilament and it is the polyamide suture. It is a non-absorbable. It is having also least tissue reaction, and it is having also good memory. And patient good memory means basically Ethlon will be using to secure the drain, to approximate the skin. Okay, so basically it is also having good memory, so you have to take minimum 4 to 6 knots during it while taking Ethlon. Okay, so basically you have to, when you are taking a suture material, no, first identify the suture material. In that most of the suture material it is written. Next, go for the needle size, which is 20, 30. Next, tell the which type of, whether it is reverse cutting, round body, taper point is there, or cutting is there, or blunt needle is there. So after that, okay, so once it is everything is done, you have to tell the examiner what is it is basically its a brand name, or what is it is generic name, what is its rate of absorption, how is the plasticity, how is the tissue reaction, and how is the holding the capacity of the suture material. And you, if any specific usage is there, you have to tell the usage. 1 or 2 usage is enough. Okay, so next is coming to our forceps. So first is our Alice forceps. So Alice forceps is also having boring, ratchet is there, shaft is there, it is having box joint, and terminal jaws or tooth end you will be having multiple tooth with serration. So what is the use of Alice forceps? So Alice forceps you will be using to hold any tough structure, such as your aponeurosis, or your any linea alba is there, or extra oblique aponeurosis is there. You will be using Alice forceps to hold the tough structures. So first is our Alice forceps. Next one is our De Becky plane and tooth forceps. So these are the plane and tooth forceps. If you are taking any skin sutures, you want to hold the skin so that your needle should enter the perpendicular into the skin. So one is the plane forceps is to hold any vascular or any delicate structure, and tooth forceps used for the any tough structure such as fascia or aponeurosis. So basically the forceps is having multiple serrations, and there are transverse ridges are present at the end, so that it should not get slip easily. So next one is your Adson's forceps. Adson's forceps is a smaller in size. It is having serrations to hold it properly, and multiple it is having at the terminal, it is having small tooth is there. Basically Adson's forceps for better grip, and it is a smaller in size compared to our tooth forceps. De Becky tooth forceps is bigger in size, but Adson's forceps is smaller in size. It is also used to hold the, if you want to take any subcutaneous suture, if you want to hold any fascia or any delicate structure, you can use it, but there are tooth ends are there, so there is a chances of injury. So coming to our De Becky vascular forceps. So De Becky vascular forceps, these are the longer in size compared to our Adson's. So these are having serrations at the end, but these are the non-tooth end. So during vascular surgery, you will be having you will be using deep Baker vascular forceps. So these are the least traumatic forceps, most commonly used in the vascular surgery or any kind of resection anastomosis during bowel handling, or you want to hold any vessel, okay, or you want to hold any nerves, important structure, deep Baker vascular forceps. So next one is our chiatal forceps. Chiatal forceps is also having boring, but there is a no ratchet is present. It is having shaft, and at the jaw it is having box end, but jaw ends there is a there are ends or sickle shaped jaw ends are present. So basically chiatal forceps will be using during if you are operating, if you want to take any dressing material from autoclave drum, so you don't want to put directly your hands to make it disinfection or sterilize, so you'll be putting the chiatal forceps to take the material from your autoclave drum. It could be your drapes, or it could be your any dressing material, or it could be any your instrument. So you'll be using the chiatal forceps to get the instrument from your autoclave drum. So next one is your Satinsky vascular clamp. So Satinsky vascular clamp, okay, it is also having boring, ratchet is there, shaft is there, box joint is there, but at the terminal, no, jaws are having up to 45 to 60 degree bend is there, and these are having there are no tooths or any there are only having transfer serration is there. Basically, Satinsky vascular clamp is used to apply the clamp to the major vessel, such as any IVC, inferior vena cava, or any aorta is there, or suppose if you are operating any case of nephrectomy, by mistakenly you have taken any nick or injury to the inferior vena cava because your left side renal vein is shorter in size, so there are higher chances of bleeding from inferior vena cava. So to arrest the temporary hemostasis, you can apply the Satinsky vascular clamp, because it causes least tissue damage, so that you will be taking the suture material to arrest the hemostasis or repair any vascular structure. So that is your vascular clamp, Satinsky clamp. It is having 45 to 60 degree bend at the terminal end. So coming to Lahey's forceps, it is also same like your Satinsky forceps, but it is smaller in size. But one important point is that it is having 90 degree bend at the jaw end. Okay, so it is having 90 degree bend at the jaw end. So that is the Lahey's forceps for the hemostatic achievement. So next one is our Doyne's intestinal bowel clamp. So as I told you in the beginning, it is also having boring, ratchet is there, shaft is there, but the jaw is the longest part in this instrument. Okay, and jaws are having longitudinal serration. So what is the importance of longitudinal serrations? So these are the longitudinal serration. It causes least trauma to the tissues. So it causes least trauma to the bowel. So that is the importance of your longitudinal serrations. Okay, so this is the importance of your Doyne's intestinal clamp, basically to use for the resection anastomosis. So this is our Babcock forceps. Same like all the instrument, it is having the feature at the terminal end there are fenestration. Two fenestrations are there with the cavity in between the fenestration to pass the any tubular structures to cause the least tissue injury. So basically this Babcock forceps you will use during your appendicectomy. You will be needing minimum 3 Babcock forceps, one to hold the tip, one to hold the base, next to hold the one to hold the tip, one to hold the shaft, next to hold your base of the appendix. So this is your Babcock forceps. You can use to hold the small bowel also. This causes least tissue trauma. So coming to a Rampley sponge holding forceps. So Rampley sponge holding forceps, it is also having fenestration with the transfer ridges. So basically this Rampley sponge holding forceps will be using for to hold the sponge during painting of the operative field before the surgery. Okay, so apart from your painting, you can, if there are no ohm forceps is available, Rampley sponge holding forceps, you will be using this during to remove the product of conception if there are no ohm forceps available. And also you can use the Rampley sponge holding forceps to hold the fundus of the gallbladder during difficult cholecystectomy, or you can use the hold the Hartmann's pouch. Okay, for the, or you can, if there are hydatid cyst is there in the liver, you have to hold the membrane of the hydatid cyst, you have to hold the wall of the hydatid cyst. You can use the Rampley sponge holding forceps. Apart from your painting, you will be using to remove the product of conception. You will be holding the fundus of the gallbladder during cholecystectomy. You will be holding Hartmann's pouch also during cholecystectomy, or you can hold the any cyst in the liver, that is hydatid cyst or wall of the hydatid cyst during surgery. That is your Rampley sponge holding forceps. This is our Desjardins forceps. How to identify Desjardins forceps? There are no ratchets. Okay, it is the only one instrument. It is even though it is a forceps, it is having screw joint. You can screw the screw joint, and apart from that, it is having curved tooths with fenestration at the end. Okay, curved tooths with fenestration at the end. Why there are fenestration at the end? See, basically Desjardins forceps is used to remove the common bile duct stones. So if there are no fenestration, you can crush the stone so that stone will get deposited in the abdominal cavity, or stone will remain in the CBD itself. So you don't want to crush the stone, that's why there is a gap is there. And curved because our CBD is not like straight, so that you can put easily inside the common bile duct to take the stone out. So that's why it is curved and it is fenestrated, why there is no ratchet to have the freely mobility. So that is important Desjardins forceps. So apart from your CBD stone removal, where you can use the Desjardins forceps, suppose you have done the laparoscopic cholecystectomy, you want to take out the specimen, basically will take out the specimen from your umbilical port only. But your specimen is not coming because of large stone in the gallbladder. So what will you do? You take the gallbladder till the umbilical port, insert your Desjardins forceps, crush all the stones within the gallbladder. Once the stone is crushed, no, the specimen size will become less, then take out the specimen. So if you want to take out the laparoscopic cholecystectomy specimen, you can use the Desjardins forceps. Next, coming to your bulldog vascular clamp. So this is the vascular clamp with pincer like mechanism to achieve the temporary hemostasis. So you will be using the bulldog vascular clamp. Next clamps are coming to our clamps, vascular clamps. Next clamp is our Kelly's curved hemostatic forceps. So this is the Kelly's curved hemostatic forceps. So basically how to identify this is Kelly's, this is also boring, ratchet is there, shaft is there, box joint is there, and jaws are there with the transverse serrations. And in this image it is not showing, but the transverse serrations are complete throughout the our jaws. It is not like 50% this image showing. Serrations are there throughout the complete jaws, and jaw length and instrument length is divided into 50-50. Okay, how much is the jaw length and rest of the instrument length is 50-50%. So that is your Kelly's curved hemostatic, or you will be having straight forceps. Next one is your Spencer well hemostatic forceps. Okay, so next one is your Spencer well hemostatic forceps. So how to identify Spencer well hemostatic forceps? So basically Spencer well hemostatic forceps, it is having jaw length is 1/3 compared to our instrument size. So Spencer well hemostatic forceps is having jaw length of 1/3, but our Kelly's, it is having jaw length half of the instrument. In our Spencer well hemostatic forceps, jaw length is only 1/3 compared to our instrument, with there is a transverse serration is there. How to identify there is Adson's hemostatic forceps? So most of the time you will get confused with Adson's hemostatic forceps or your Kelly's curved hemostatic forceps. So Adson's hemostatic forceps, there are it's same like Kelly's forceps, but jaw length is only 1/3, and there are transverse serration present only at the tip, or you can tell only at the 50% of the jaws, not entirely as like our Kelly's hemostatic forceps. Okay, so how to identify Adson's? Same like your Kelly's, except jaw length is only 1/3, and there are transverse serrations are not completely present at the jaw point, it is only present up to 1/3. This is how you will be identifying your Adson's hemostatic forceps. Next one is our fistula probe. So fistula probe is used during open fistulectomy, okay, to identify the tracts of the fistula. So you will be having eye at the bottom for secure grip, so that secure grip also, and you can pass your suture also to ligate the interfissular tract, that is called as a lift, ligation of interfissular tract, that is lift. And also there is a pointed rounded tip, rounded tip is present in front to prevent any trauma, so that you will be not having any false tract. If you are having any sharp object, no, you will, while doing fistula tract probing, no, if there it leads to false false passage because of your sharp. So that's why it is a rounded tip to leads to a rounded tip, so that it should not give any false impression of false tract. Okay, so this is your fistula probe. Next one coming is your our Kayer's T tube. So basically Kayer's T tube is used after CBD exploration. So you are seeing one umbrella shape, that is the horizontal limb, and you are seeing one vertical limb. Okay, so that umbrella shaped horizontal limb, one part will be going in the common hepatic duct up to 3 centimeter, and one part will be going in the common bile duct. Common hepatic duct will be upper part and common bile duct will be below. So one part is going, one tip of that umbrella, no, suppose the left side of tip will go into the common hepatic duct, right side of tip will go into the common bile duct, as in the you are seeing this image, no. Okay, one part is going into common hepatic, one part is going to common bile duct, and through that you have to repair the CBD. And lateral aspect, not in the same repair aspect, lateral aspect of CBD, you have to take out the vertical limb and take out from the abdomen like this, take out from the abdominal wall, then give connection with your any kind of your drainage bag. See, basically you have to monitor the bile output, you have to monitor, you have to send for any culture, bile is coming or not. Basically 8 to 10 days you have to do the T-tube cholangiogram to look for any residual stones or any kind of retained stones in the CBD. Why 8 to 10 days? Because after 8 to 10 days there is a formation of tract is there. Okay, so if you are done T-tube cholangiogram, it is showing any retained stone, you will be giving wash through your T-tube, so that that stone will go out or it will come out through your T-tube. Okay, so that is the important of doing 8 to 10 days T-tube cholangiogram. Why 8 to 10 days? It leads to formation of tract during 8 to 10 days. Okay, that is a one aspect. And when to remove the T-tube? You have to remove the T-tubes after 14 days. If you have done T-tube cholangiogram, it is showing normal. And before taking T-tube cholangiogram, you have to clamp the T-tube 1 day before the removal, so that you have to monitor patient should not be having any distress, there is no abdominal distension, there are no signs of any biliary peritonitis. If the patient is doing well, you have to remove the T-tube like normally, just you have to pull it out, it will come off. So that is your Kehr's T-tube. This instrument is showing your female metallic catheter. If suppose you are operating any pelvic surgery, female bladder is full, you are not inserted bladder, you are not inserted the Foley's, you will be having difficult. So you will be using the metallic catheter, that front end the serrations are, you will be just emptying the bladder temporarily, you will removing out, bladder will be it will get emptied, you can easily operate. So this is for pelvic surgery female patients. So this is a female metallic catheter. So coming to our Kelly's rectal speculum. So basically speculum or it is also called as proctoscope, used for examination of a rectum and anal canal basically. So what is the position of the patient? Patient will be the left lateral position. So that top image is showing a speculum proper and that below image is showing your obturator. So there are two parts, one is your speculum proper and below image is showing your obturator proper. So a patient will be in the left lateral position. You have to explain the patient, you have to take the consent of the patient before doing proctoscope. You have to rule out whether patient is having any acute fissure in ano. You have to rule out whether patient is having any thrombosed piles. Okay, so those are the contraindication. Before doing proctoscope, you have to lubricate with using 2% xylocaine. Ask the patient to take breathing through the mouth. Ask the patient to sleep properly in the relaxed state. So your left lateral position of the patient, and ask the patient to extend the lower limb, that is your left lower limb, extend the patient, and ask the patient to flex the right lower limb, that will be in the upper part. Ask the patient to flex the right limb, okay, at the knee joint, at the thigh joint, up to abdomen. First guide the proctoscope, okay, it will be anterior and forward in the direction of umbilicus. And next, as it goes into the anterior and forwards towards umbilical, next change the direction anteriorly and upwards towards the sacrum. First you will be going anterior and forwards towards the umbilicus, next change the direction anterior and upwards towards the sacrum, and remove the obturator. Some proctoscope will be having internal light inside, and some proctoscope you have to give the light source from external side. So remove the obturator and come back slowly, and while coming back, see the anal canal, see the rectal mucosa, if there is any growth, anything is there. So basically it is used for diagnostic purpose. If there are any polyps are there, if there are any internal hemorrhoids are there, those are the causes of bleeding. If there are any growth is there, those are causes of constipation. And for therapeutic also, if there are grade 2, grade 3 hemorrhoids are there, you can use the sclerosant. Go do the proctoscope, insert your needle, inject the sclerosant at the base of your hemorrhoid. So that is your therapeutic aspect. If there are any polypi there, you can remove the polypectomy through the proctoscope. You can do if there are any internal hemorrhoids are there, you can do the ligation of the internal hemorrhoids, and you will be using the Chivete method is there, Chivete maneuver is there, you will be using the Chivete's method of internal hemorrhoid ligation. So this is your Kelly's rectal proctoscope. So these are all the instrument we have covered with the general surgery instrument, most of the time open instrument, and some catheter and basic suture material, how to identify suture material, what are the types of needle, and what are the some other instrument. Okay, so go make notes, revise it properly. If you have any doubts, kindly message us in Instagram also, we are there, that is our name is Everest Surgeon. Our WhatsApp channel is also available, our YouTube channel is also available, Everest Surgeon. Please contact us if you have any doubts, or if you want to participate in teaching, you are free to encourage anyone. You can join in our group. So there is no any restriction, you can join us in the teaching our surgical community. Thank you. Happy learning.